Bismillah Rahman Rahim. Ladies and gentlemen, let me to welcome you all to this very interesting webinar. I am Dr. Ahmed Abdurrahim, Associate Professor of Medical Diagnostic Ultrasound, Dean Faculty of Graduate Studies, Zaim Al Azhar University, Sudan. On behalf the Director of Afro-Asian Institute, Professor dramirgilani. Let me again to welcome you all, ladies and gentlemen. The topic of the day is knowing placenta on ultrasound, and the speaker is Professor dramirgilani, Director of Afro-Asian Institute and Dean Faculty of Allied Sciences, Lahore University, Pakistan. So, Professor, mic is with you.
Thank you very much, Dr. Ahmed Abdurrahim, and thanks to the team of Afro-Asian Institute. My topic today is knowing placenta on ultrasound. So we will talk about some important things along with basics of sonography of placenta. If we look at the development of placenta, we will come to know that the sonographic appearance at different gestational age varies. At approximately 8 weeks of gestation, at ultrasound, we can see the focal thickening of gestational sac wall, and at 12 weeks, we can get a placenta which is visible as a mass, echogenicity similar to myometrium. Then at 16 weeks, we can get fetus and placenta of almost similar size. At 20 weeks plus, 2 to 3 centimeters thick, maximum will be 5 centimeter in thickness. At gestational age of 29 weeks, there will be calcifications, echogenicity which is visible, and at 33 weeks, we can see 50% of the cases, 50% of the placenta will show foci of calcification, which are the hyperechoic spots. The reference is there. If we look at the anatomy, which is very simple, we can see the villi here. Then we have got the limiting or boundary layer of the maternal vessels, which are these vessels. Then is the stratum spongiosum. And we have got placental septum here. Then are the amnion here, then is the chorion, the marginal sinus. We have got the trophoblast at this area. Then the umbilical cord, which has got umbilical arteries and vein. If we look at the early pregnancy, the sonographic appearance will be like this. It is the early gestation. You can see a sac, which is anembryonic. The embryo is not yet visible. And then comes the normal gestational sac. We have got a yolk sac inside, a bubble-like appearance, a small hyperechoic area with anechoic interior. We can measure it at this stage. Look at this, it is 0.42 centimeters, which is 4.2 millimeter, which looks normal. So we have to keep in mind that at this stage, it will grow 1 mm per day. And another important thing is that the embryo should be seen at around 16 to 20 sac diameter. Whenever the sac diameter, mean sac diameter is 16 to 20, we must get embryo visible if it is normal. Then 6 weeks crown rump length. This is how we measure from crown to the rump, and normal cardiac activity, which can be seen on M mode. In this case, you can see there is activity. In late first trimester, the placenta starts appearing. It will be a bit hyperechoic. You can see it is almost similar to the echogenicity of the myometrium, and it starts becoming hyperechoic as compared to underlying myometrium. Here is the embryo, and it is important when performing CVS because we have to see from where we will get the chorion will lie sampling and which approach will be used so that we can avoid the fetal parts. Placental ultrasound, what to look for? The location where it lies, its grade 0, 1, 2, or 3, the shape, size, and edge. Edge means the ends, then cord insertion in placenta, number of lobes and connecting vessels, architecture, vesicles, lakes, infarcts, masses, subchorionic collections, etc. So we have to keep in mind, especially for the beginners, that we have to keep in mind that we will see all these things. We will not just look for placental grade and its location. We have to see many other things, and these things are very important to see, like vesicles, lakes, infarcts, masses, because they affect the outcome. Retroplacental areas like myometrial interface, fluid collections, etc. According to American Institute of Ultrasound and Medicine, they have given some guidelines, which are the specifications. First trimester, no mention of placental imaging except for determination of chorionicity in multiple gestation. So once we are reporting, we usually don't mention placenta because the placenta will not be that much visible if it is normal. So we just mention the chorionicity in multiple gestation, that how many placentas are there. Then in second and third trimester ultrasound, placental location, appearance, and relationship to the internal cervical loss is need to be reported. We have to look for umbilical cord with number of vessels. We can have 2-vessel cord. Normally it is 3-vessel cord. No specific mention of placental cord insertion. We usually don't mention it unless it is abnormal. Then is the placental location. Either it is lying interiorly, posteriorly, laterally, fundal, low-lying, previa. Let's see how we look for these locations. If you look at this, this is the anterior abdominal wall of the patient. There is internal loss, external loss, and the cervix. We can see the whole uterine cavity. This is fundus of the uterus. So the area of the placenta, which is near to the transducer towards the anterior abdominal wall of the patient, is interior. And then away from it towards the towards the vertebra will be posterior, and anything near to the internal loss will be previa, whereas the foretype will be the fundal, which is towards the fundal end of the uterus. Then we get a transverse uterus. This was the sagittal view. Then if we remove the transducer transversely, the probe head will be on the lateral side, on the right side of the patient. Patient is lying supine. And then we scan, you can see the right lateral and left lateral side. So once we are scanning, we will scan for locations. We will scan longitudinally, which is the sagittal view, ruling out either it is fundal, previa, anterior, or posterior. And then we will look for right lateral or left lateral. There are types of placenta previa. The low-lying, which is the low-lying edge within 2 to 3 centimeters of internal loss, but not covering os. Marginal previa is an edge touching internal loss, but not covering it. Whereas partial previa is edge just covering internal loss. A complete or total previa is placenta completely covering internal loss. So in previa, it will be partially covering, whereas in complete or total previa, it will be covering whole of the internal loss. But central previa is center of placenta implanted over internal loss. I usually give example like this, that if this is the internal loss and here is the placenta, if the center of the placenta is at the internal loss, let's see like this. If it is at the center, then it is central. Placenta previa complete, which is central. Then placenta previa, which is acentral. which is, although it is complete previa, but it is in the center of the placenta is not at the internal os. So we will have low-lying placenta, then is marginal placenta, then is the partial previa. Then we have got complete previa, and complete previa can be of two types, the central or symmetrical, and the other is asymmetrical or acentral. Here are a few examples. You can see the cervix. This is the external os, the internal os. Then we have got the, here you can see the cavity, and here is the placenta. We will see how long is the distance. If it is 2 centimeter, then we will say 2 centimeter or above, we will say it is low lying, 2 to 3 centimeter. If it is less than 2 centimeter, we will say that it is marginalis. So this is a complete placenta previa. Here you can see the os. This is vagina. Here is the external os, internal os, urinary bladder, amniotic fluid cavity, and the umbilical cord parts are there. This is placenta, which is covering up to here. So it is asymmetrical complete placenta previa. We have to keep one thing in mind, that if we are scanning patient at this stage, the TVS ultrasound does not cause bleeding, and it is necessary for correct diagnosis of placenta previa. So we can have a TVS or a labial ultrasound, translabial ultrasound, so that we can diagnose the placenta previa completely. The resolution of placenta previa. TVS, transvaginal sonography in patients with apparent low-lying placentas on transabdominal scan at 15 to 24 weeks improves accuracy of diagnosis of placenta previa. So if we have diagnosed transabdominally that there is low-lying placenta, it is better to go for TVS or translabial ultrasound to confirm it. 1.1% incidence using TVS, and 85% resolved before term. We have to see that if they are low-lying placentas and we have diagnosed by TVS, then according to the literature I have mentioned here, there are 3 studies. 85% of low-lying placentas will be resolved. Amount of overlap correlates with probability persistence at delivery, and overlap, which is about 2.5 mm at 20 to 24 weeks, will be 40%, and overlap which is above 2.5 millimeters, it can, which is at 20 to 24 weeks, there will be no resolution. So if the covering area is less than 2.5 millimeters, then there are 40% that it will resolve, it will go away. Whereas if it is above 2.5 millimeters covering the internal os, the assessment is at about 20 to 24 weeks according to these studies, then no resolution. No, it will not be resolved. Thick edge of low-lying placenta. So first we described low-lying, then we discussed the partial placenta previa, which is the partialis. The thick edge of low-lying placenta statistically increases risk of antepartum hemorrhage compared to thin edge. Here is another thing. You can see vasa previa, and this is how the vessels are the presenting part. This is placenta internal os, and here is the vessel on Doppler. You can see the placenta is here, and internal os is here. This is the cervix, and presenting part is this one. So there is a study that, according to the literature, about 1 out of 3,000 births, there will be vasa previa. So if we scan a patient at a specific gestational age, the chances of vasa previa, according to the literature, will be 1 out of 3,000. Fetus has 100 cc blood per kg. So 300 cc at term. So 60 to 90% fetal mortality if not diagnosed antenatally. If we don't diagnose it antenatally, then 60 to 90% fetal mortality can occur. So therefore, it is very important because a lot of blood is there, 300 cc at term in this presenting part. So that can cause a lot of damage to the fetus. And so we have to diagnose it earlier. So better to use once we are looking for placenta, its edges, especially when they are a bit low lying, then we have to put Doppler to see if there is a presenting vessel or not, because it can be dangerous if we don't diagnose it. There is no standard of care to look for vasa previa, but routine examination is important. We can use TVS, and even on transabdominal scan, we can diagnose vasa previa. Another important thing is that when there are multiple pregnancies, then we also have to see for vasa previa, because once we have twins or multiple fetuses, we usually start performing their biometry and looking for anomalies, and we forget about vasa previa. One of the umbilical cord can be presenting part in such cases. Similarly, we can have succinturate lobes along with vasa previa, so the color Doppler scanning will be important. This can be a cause of second or third trimester bleeding also, and we can distinguish from phunic presentation and maternal vessels. The phunic presentation means when the vasa previa is there, when the vessels are presenting, we call it as phunic presentation, and fetal vessels which are plastered against uterine wall over or near the internal os, like we can see, it is along the wall, and you can see the vasa previa. So we call it is a phunic presentation. We use the word phunic once it is vasa previa, but it is a bit along with the wall of the myometrium. So this term is used. Then is placental grade. Calcium deposits are important, and we can have different grades. Normal placental aging process is also called as placental grading, and microscopic early in pregnancy. After 33 weeks, 50% of placentas have microscopic calcification that increases until term, and cigarette smoking associated with accelerated placental grading if the mother is a smoker. Grade 3 is not a predictor of IUGR. We have to keep in mind that it is not a predictor that once we get grade 3, there will be more complications. So after 36 weeks, grade 3 placenta can be normal finding. And before 34 weeks, we can predict that there may be some prediction of perinatal complications, but still it is controversial and conflicting statement, because there are very small studies which go in favor of this point. Which point? The point is that if there are more than 50% of placenta having macrocalcifications, then we can have perinatal complications. This statement is controversial, and as it is based on smaller studies. So still we can say that once we get grade 3, even before 34 weeks, the chances of complications will be less, but we must be alert if we find it before 34 weeks. There is no compelling evidence to suggest that premature placental maturation alone should guide an obstetrician to decide. This is grade 0, no visible calcifications, smooth chorionic plate, appears homogeneously gray. Then is the grade 1, very small, tiny. Here you can see the calcification. You can see small areas which are hyperechoic, and then subtle indentations of chorionic plate. This is large basal coma-like areas here, which are the echo densities. Larger the indentations are visible, the indentations are in the chorionic plate. Then is grade 3. In grade 3, we can have extensive basal echogenicity and circular echo densities, fully outlying cotyledons, complete indentations of chorionic plate. Then we have the minor and major, which are, this is the previa, which is complete symmetrical previa. This is the marginalis. Here you can see the placenta, which is the previa minor. This is another condition. Here it is touching the os, so it is minor or marginalis. So transvaginal scan of grayscale in the patient at 3rd trimester, the placenta completely covers the intrauterine os, which is the cervical os, sorry. Then is the placentomegaly, which is the thickening of the placenta. Thickness is in millimeters, approximately gestational age in weeks plus minus 10 mm. So if it is 40 weeks, it can be 30 to 50 mm. If it is 30 weeks, it can be 20 to 40 mm. So term placenta should not exceed 40 to 60 mm and do not measure thickness at point of curvature. Here it is the flattened placenta and polyhydramnios. You can see due to polyhydramnios, this is thin placenta. Placental shapes and edge are important. This is the normal, the basal plate, the chorionic plate. And if it is circummarginate, it can look like this. This is the circumvallate. So we were talking about placental shape and edge. This is normal. This is the basal plate, and this one is the chorionic plate. And here is the circummarginate. This is circumvallate. We will see how we differentiate between them. In circumvallate, the chorionic plate is smaller and the basal plate is larger. And it is associated with placental abruption, stillbirth, and preterm labor. Difficult to distinguish with ultrasound. The normal placental cord insertion is in the center. Here it is the center. And it can be on the side. About 2 to 10% of deliveries, cord insertion within 2 centimeters of placental edge. Cord inserts identifies original placental implantation, and also known as centric or marginal insertion. So it is not on the center, it is away from the center, around 2 centimeters from the placental edge, from the corner. So we also called it battledore and shuttlecock, like this. We can call it shuttlecock or battledore or centric placenta, which is the cord insertion. Well-methods cord insertion, the incidence is 1 out of 100 insertions. It will be an insertion which will be outside the placenta. This is placenta and cord insertion is here. And the cord vessels are branching outside the placental body. Increased risk of IUGR and cord rupture are there, and more common in single umbilical artery conditions, which is about 9%. There will be risk of monochorionic twins or the twin-to-twin transfusion syndrome. This is accentuate low, no clinical significance, and no vasa previa. Be aware of manual removal. Membrane should drag out second lobe, and then spontaneously we can have about 10% of deliveries which are having mild, minor type of complications during delivery. Subchorionic fibrin deposit, this is the fibrin which is deposited, and we can have the placental lakes within the placenta. Normal finding in second to third trimester may be numerous, no clinical significance, anechoic and swirling venous blood visualized. We can have infarcts. There is a loss of perfusion and causing necrosis of tissues. We can have, if more than third or half of the placental parenchyma is infarcted, fetal demise is more common. So if it is 50% to 70%, we can have fetal demise. Liquefaction of blood make infarct visible by ultrasound, and irregularly shaped. We can see this is the liquefaction, and here is the infarct. On Doppler, there is no flow. We can have complete molar pregnancy. So it is not a placenta, it is a mole, which is hydrated form mole. Then is the placental abruption. Retroplacental bleeds are important. This is placenta, and behind it, between the myometrium and placenta, there is the bleed. And we can predict about 50% of abruptions, especially when they are very small. It is usually difficult to find it, but we can find about 50%. It also depends on our expertise and the machine we are using. Use history and clinical findings like bleeding, contractions, pain, and we have to differentiate it from the retroplacental complex, and we have to see if it is a bleed or it is hematoma. So always look the area which is retroplacental, which is between the myometrium and placenta. You can see retroplacental, it can cause separation. Subchorionic bleed in early gestation, and in late, we call it retroplacental, because in the beginning, when placenta is forming, we call it chorion. Incidence is 1.3% in first trimester, and we can see 9.3% risk of subchorionic bleeds and visualized bleed and cardiac activity. Increased risk is there, which can cause some of the abruptions. This is normal myometrium and placenta. And then comes the placenta Krita spectrum. A Krita is abnormal adherence of myometrial surface. In Krita, invasion into the myometrium. Per Krita, invasion through myometrium into bladder wall or bladder activity. And then here you can see, we can see some of the areas where you can find that some changes, heterogeneous areas are there. We can ask about C-section history or any uterine surgery, because once we are scanning, if we miss it, it can be very dangerous. Ultrasound is about 80% sensitive in high-risk women. Maternal mortality is 7 to 15%, and 90% cases we need transfusion, because there will be bleed if it is in Krita or per Krita. This is placenta per Krita. The placenta has, here you can see, it has invaded the myometrium. This is urinary bladder. It has gone into the urinary bladder, and we can see the flow. These are more cases. So we can perform transabdominal, even the TVS. Here is the normal placenta, the interface of placenta and underlying myometrium. Once it invades, it is per Krita. You can see this is how we differentiate. The next slide. Here is the placenta, and you can see the myometrium. This is normal when it is touching. When it goes in, it is a Krita. When it has entered the myometrium, it is in Krita, but it has not crossed it. But once it has crossed the myometrium, then it is per Krita. It can go to the urinary bladder. You can see here the interface. This is again the per Krita. The placenta has invaded the myometrium. This is the intraparenchymal placental leucine, the vascular spaces. When we put colors, we will get the Doppler flow. These are with the color Doppler. This is with power Doppler. And you can see the urinary bladder. Placenta is invading. You can see the placenta here. And when we put colors on it, these are the colors. The interpretation of the thinning of the interface between uterine serosa and bladder wall are caused. And this helps us because you can see the urinary bladder here, and it has invaded whole of the area. We can use tissue harmonics and 3D, 4D for it. This is the placenta Krita. You can see within the bladder, there is presence of placenta. We can also have some tumors like this one is the chorioangioma. So we can use surgical specimens, 3D color power Doppler image that shows the hypervascularity.